Hi, Dr. Smilu. Hello.
Hi, ma'am. Hello, good evening.
Good evening. Thanks for being here.
Yeah, I'm there. I'm there.
Okay, wait. You want
Yeah.
to, Miss Chetana, can you allow her to see if her thing is working? Screen is working? Miss Chetana? Chetana? Okay. I'll just call her. Is this thing?
Okay, ma'am. No problem.
Hello, Miss Chetana. Can you allow her to screen share so that she can check it? Yeah. Hello?
1 second, ma'am. I'll just,
She's going to try and check.
yeah. So I'll just share my screen. Yeah. Is my screen visible?
Yeah, ma'am.
Yeah, it goes in the presentation.
Visible,
There is no.
visible.
Okay.
Thank you.
Right. Okay, thank you. I'll unshare now.
Hi, Anne. Good evening. Smilu, good evening.
Good evening, sir. How are you, sir?
I'm good. How are you?
Good, sir. Good.
Good evening, Dr. Ramesh.
Hi, Anne. Good evening.
Hi. It's good to see you.
Same here.
Dr. Neha, is that Dr. Neha, developmental pediatrician? Hi. Usually people join a little bit late. So, Dr. Ramesh, would you mind checking your PowerPoint PPT as well?
What did it say? Share it, is it?
Yeah, just to see if it works.
Okay.
It will work.
Yeah.
Dr.
Definitely.
Hi, welcome, Dr. Sujata. Dr. Sujata is a pediatric neurologist
Hi, Anne.
developmental
Can you
pediatrician
see
Hello,
this?
Anne.
from Coimbatore. Yeah, visible. Thank you.
Okay, sure.
I'm going to, while you're waiting, no? We'll anyway, usually we wait for 5 minutes before we
Okay.
start. I'm going to
Mhm.
contact the chair. The moderator is, so the moderator is a very, very senior neurologist.
Okay, sure.
Dr. Radhika has also joined. All three speakers are here. Let me just remind the moderator. Just give me a second. Hi, Dr. Radhika. All the two of the other speakers have checked their, Dr. Radhika? Dr. Radhika?
Yes. Hi.
Hi. Hi. All the other speakers have checked their screens, their screen sharing. Would you like to
Can I
check your screen
do that?
sharing?
Yeah.
Ah, the man of the hour. I was just going to boast about you, Dr. HVS. Dr. Ramya knows about Dr. HVS. Dr. Radhika knows about Dr. HVS, no? Yeah, because you're from Bangalore. Others outside Bangalore, I don't know how many of you know. Your screen is also working. Okay, so we have all our speakers before time, Dr. Srinivas. You're not audible, sir.
Muted it. Now I am audible.
Now we are audible. Sir,
Yeah.
so far the ones that are here, we have some nice people here. You have your speakers. Along with that, Dr. Sujata Chinnappan is a pediatric neurologist from Coimbatore who trained in UK. ORDI is the one that is hosting it, Organization for Rare Diseases India. We have to thank them because we don't have to rely on pharma funding for this because of them. They have provided this subscription and they allow us to do this monthly meets, educational meets on behalf of rare diseases. Dr. Arijit is a pediatric neurologist who's senior to me. He trained together with me he trained with me in Great Ormond Street in London. He's based in Kolkata at the moment. Ramya is my fellow, but now she's working in the UK. Dr. Vinita is unique and one of her kind. She is a physical medicine and rehabilitation specialist who comes up, she and her team comes up with innovative orthoses and cheap ways of modifying wheelchairs. Hi, Dr. Vinita.
Hi, ma'am. Hi, hi.
Let Dr. HVS see your face. So we are very proud of her and her team. So they're also presenting what they're doing in Prague in the World Muscle Society. They're coming to Prague, Dr. Smilu, Dr. Vinita, and the rest of them.
Very nice. I have
So-
also referred couple of patients to Vinita. So as of now, whenever I'm needing a good orthosis and wheelchair modifications and all.
Sir, imagine, sir, that's patients deferred from Kerala to Bangalore for wheelchair modification. She's an adult trained person, but we have lured her to pediatrics. So she likes pediatrics more than adult.
I'll be learning from this particular seminar, webinar, whatever. it may
We'll
call.
all be we'll all be learning. Dr. Debashish Bhattacharya is
Yes.
a surgeon. He's a surgeon who's running a rehab center. He recently relocated from the UK, and he's running a high-end, proper rehab, very posh kind of setting for assisted living and rehab. So, yeah.
Thank you very much, Dr. Anne, for this introduction. I'm most honored to be listening in today, so I'm now going to keep quiet and listen to all the experts. Thank you very much.
So, while I'm making some friendly, casual talk while we're waiting for people, because we usually wait 5 minutes, sir. 5 minutes and then we start, because
Okay,
people
no
are just
problem.
joining in. So while we're waiting, for those of you who are, most of us know Dr. HVS, but for those of you who do not know Dr. HVS, he has been, sir, you can close your ears if you don't want to listen. He has been a mentor and a role model for many people, because he's the first accredited trained neurologist of the state of Karnataka. He's very senior, and his sir is very committed to education, and his Wednesday weekly sessions are like, they're legend. So the first pediatric neurologist of India, your senior, Ramesh's senior, Mahesh Kamante, no? He was inspired by Dr. HVS to become pediatric neurologist. He used to attend sir's classes, and only then he applied and became a pediatric neurologist. He applied to AIMS and things. So Dr. Ramesh is trained in AIMS.
Good evening,
So-
sir.
So sir is, and despite all of that, sir has started many.
Can I, before you start the session, can I talk something?
Yes, sir, please do.
Yeah, I just want to say that during my lifetime, I have seen the changes in the neurosciences. Just to recapitulate, it was in 1951, 4 people, 3 neurosurgeons and 1 neurologist started Neurological Society of India. Only 4 persons starting an association, Neurological Society of India, 3 surgeons and 1 physician. And as you're all aware, the surgeons always overpower the physicians, because the patients have a lot more respect for surgeons, because they want to make sure that they will come back alive from the OT. So the neurologists felt they have been sidelined and they have not been looked after properly in the NSI. So we formed Indian Academy of Neurology in 1991. And today we have, at that time it was 40 members, and today we have 3,000 plus members neurologists. When I was a faculty in NIMHANS, we have not heard of CT or MR scan. We never had CT MR. So we were trained in the pre-CT, pre-MR area. At that time, when the CT and MR arrived, we were learning along with our students. We didn't have any pediatric neurology at that time when I was a teacher there in NIMHANS. In fact, you must have heard of Suresh Arur, who is a very leading pediatric neurologist. He was my student. I was teaching him neurology and he was teaching me pediatrics. And then subsequently, of course, a lot of improvements have happened. So many pediatric neurologists have come in, departments have come in. And then came the improvement in technology, genetics and biochemistry, histopathology, and so on. So now we have a lot of subspecialties, and I'm very glad to see that today I'm part of the highly specialized subspecialty SMA. And Dr. Anne is very, very passionate about it along with her friends here. I told her, I am not a pediatric person. Why are you calling me? So she said, you come and learn from us. So I said, okay.
Sir, I did not say that, sir. Please don't say that. I didn't
So
say.
I said, why not? So I am here to learn from all of you. And I just gave the background of what it was like neurosciences. So now I invite the first speaker is
Sir, one thing before today's thing, only the vote of thanks I'll be giving, and then I'm going to switch my video off. But one last thing I needed to say about Dr. HVS, sir, about him is that many of these meetings he has attended, he says, I need to learn. And he's attended many times. Then I thought, why not? His is an attitude that we need to learn. We need to learn from. So, sir, on to you with a thank you to ORDI. On to you.
who is the first speaker I have to introduce? Smilu.
Yes, sir.
So the first speaker will be Dr. Smilu Mohanlal. Is a pediatric neurologist based in Aster, Kozhikode. She is a pioneer in SMA management in the state of Kerala and has first-hand experience administering all the available neurotherapy in SMA, such as nusinersen, risdiplam, and gene therapy. She is passionate advocate for individuals affected with SMA. Now I call upon Dr. Smilu Mohanlal to give her impressions on SMA.
Thank you, sir, for the introduction. Thank you, Dr. Ann, for giving me this opportunity to share a few words in this platform. I hope my screen is visible.
Yes, it's visible.
Yeah, thank you. So I'll go to the presentation. So I'm going to talk on spinal muscular atrophy updates in the management. So before I go into the update in the management, I would first talk on what is SMA and its genetic aspect. So we all know that SMA is an autosomal recessive condition. The incidence is 1 in 6,000 to 10,000 live births. The carrier frequency is 1 in 38 and 95% are caused by homozygous deletion of SMN1 gene in chromosome 5q, less frequently by point mutations. There is another separate entity called as non-5q chromosome spinal muscular atrophy. So first, to know the genetic part. So in healthy individual, all of us have this SMN1 and SMN2 gene. So the difference between SMN1 and 2 gene is at the exon 7, where there is a change from the C to the T terminal in the exon 7. So in a healthy individual, what happens is from the SMN1, there is a 100% functional mRNA that is produced. From there, a functional protein, which is 100% normal SMN protein is produced. SMN2 is also functional, but it produces a more of truncated protein and a few amount of normal SMN protein. So in child with SMA, we all know this, the SMN gene is completely absent. So the body relies on SMN2. So they produces only 90% of truncated SMN protein and only 10% of normal SMN protein. So the history of SMA dates back to 1891, where Werding and Hoffman, Werding reported the first case in 1891. So from then, it took 104 years to go for the clinical diagnosis and classification. So in 1995 came the discovery of SMN1 and the 2 gene, and 21 years later on, there were a lot of drug repositioning, drug discovery that happened. Then came the breakthrough in 2016, where FDA approval for nusinersen happened. From then on, there has been a boom in the SMA field where there is a lot of the newer therapies and newer clinical trials that have been going on, and a lot of advocacy on newborn screening that has developed in the past 7 to 8 years. So this is the history of spinal muscular atrophy. So there are non-5q SMAs which closely mimic SMAs. So some of which we all have seen as SMA-RD, various Charcot-Marie-Tooth disease syndromes with predominant axonal involvement, SMA with mitochondrial dysfunction, pontocerebellar hypoplasia. So basically, most of these conditions, either they act on the defect lies in the RNA processing and protein synthesis, and sometimes the defect lies in the protein folding, aggregation, and degradation. So here I'm talking about both SMA and SMA-like syndromes where the entire defect is either in the RNA processing or in the protein folding. Even an abnormal axonal transport or a mitochondrial dysfunction can produce an SMA-like syndromes. So there are various genes which have been implicated. So once the SMA is of our current interest. So the SMN protein is mainly because SMA is because of the defect in the RNA splicing metabolism and protein synthesis of the SMN gene. Similarly, the similar mechanism is what happens in IGH MPB2 mutation also, which is SMA-RD syndrome. So now comes to the different phenotypic classification. So initially the SMAs were classified as type 0, which is before birth, type 1 at 1A, 1B, 1C, then type 2, type 3A, 3B, 3C, and so on. Now, for the sake of easy classification, we look at the functional ability of the SMA children. So based on the functional ability, we call it as non-sitters, sitters, non-sitters, sitters, independent walkers. So non-sitters are the one which is type 1 SMA, sitters are type 2 SMA, the walking ability is type 3 and type 4 SMA. Type 3s can also lose their walking ability eventually. So these are all the basics. This is just to brush up our basics before we run into the therapeutics in the management of SMA. So we also should be aware that initially it was always thought that the SMN protein is required just for the stabilization of the alpha motor neuron. So then came to the conclusion that the SMN protein is also plays a role in maintaining the heart, the GI system, the bone remodeling. It is also very important to maintain the muscle bulk and the function. The various components of nervous system like the astrocytes, the neuromuscular junction, Schwann cells were all dependent on this SMN protein as well. Now coming to the therapeutics. So to know the basic part, we all know that there are two types of therapies. There are therapies which are SMN gene dependent. There are therapies which are SMN gene independent. So SMN gene dependent means we know that either the main aim of the therapy is to increase the SMN protein level in the body. So that is by either using an splicing mechanisms to increase the production of the SMN protein in the SMN2 gene, that is with the help of antisense oligonucleotides, that is nusinersen, or with the help of oral small molecules like that of risdiplam. Then came the replacement of the gene itself with the help of a complementary DNA, that is the Zolgensma. So that is SMN gene dependent therapies. The independent one therapies which are of current interest are the ones which are the myostatin inhibitors like apitegromab, GIM329, and the Biogen and the Alpha dependent companies which are all producing this myostatin inhibitors are of the recent boom. And traditionally, we all used to use this salbutamol, which helps in stabilizing the neuromuscular junction by decreasing the fatigue of neuromuscular junction. Then also there were fast troponin activators, that is the Reldisemty was tried, but it did not produce functional benefit in the phase 2 and the phase 2 clinical trial, and thus it was taken off. We all know about Spinraza. So we know that the Spinraza, which is nothing but the nusinersen, is an intrathecal injection. It does not cross the blood-brain barrier. It is an antisense oligonucleotide, and there have been various studies which proves that now and then that nusinersen has been really effective in treating different type of SMAs, the Endear, Cherish, and the pre-symptomatic SMA children, where the Nurture trial was also going on. So in India, around 258 children are receiving Spinraza, and the program is by the Biogen Human Direct Relief Program. So initially, the program was started in type 1 SMA children and later expanded to type 2 and type 3 children as well as the adult population. And we all know that it was the first drug that was approved for treatment of SMA in December 2016, and we also know that the cost is really exuberant. So the treatment of these children came with certain components that needs to be monitored. Like with every visit, we need to monitor their platelet count, the bleeding time, clotting time, and INR, because we definitely are doing a lumbar puncture. So we need make sure that the children are safe when we go for these procedures. And nusinersen was reported to cause some effect on the renal functions, and that's why the spot urinary protein and creatinine was monitored frequently. It's being monitored frequently, and sedation and image guidance are again patient specific. And the adverse effects that has been seen in the real world scenario is mainly on most of us would have faced about post-dural puncture headaches, and some of us have faced aseptic meningitis as well as during the treatment of nusinersen, that's Spinraza. So there have been various case reports which have been various studies. The SHINE and the EMBRACE were the trials on Spinraza as well, and they have also reported the same adverse effects, but no deaths have been reported because of Spinraza. The complications like pneumonias, respiratory infections, they're all a part of the disease per se rather than the medication as such. So the main challenge that we face in and out during this Spinraza therapy is one is the compliance. When we tell the parents in the initial phase that these children have got selected for Spinraza, they are very happy. They come for all the initial loading doses. But for the subsequent doses, especially after an year, there are dropouts. They start feeling there is an anxiety among the children, anxiety among the parents as to why we are traveling so long. And every time this child is being given intrathecal injections, and it is a painful procedure. So that anxiety does crop up these days, and we are facing dropouts in children with who are taking the Spinraza, though the medication is provided free of cost. And the technique can be really cumbersome in children with scoliosis. So the more the scoliosis, the Cobb's angle increases, the procedure becomes more cumbersome. So we need to use a fluoroscopic guidance for providing the medication as such. And it becomes even difficult when a child is having a corrected scoliosis, because the criteria for selecting is the Cobb's angle is less than 30 degree or 40 degree. But after the correction, what happens is it's all fused. The spinal canals are fused, so we cannot give the injection directly. Then a transforaminal approach has to be used, and it has to be used every time the child takes the injection. So that is difficult procedure. And aseptic meningitis. So few children who have aseptic meningitis, again, to convince them to come for a repeat injection also becomes difficult. So these are the real challenges that we face with Spinraza. But the drug is very effective, and overall it has been a good stabilization of disease process, and some of them have gained really good milestones with using Spinraza. Risdiplam, we all know about the oral molecule, which has been DCGI approved, and children receiving Risdiplam in India are more than 300, are around 300 these nowadays. And Kerala government does provide Risdiplam free of cost for all the children who are less than 12 years of age. And there are various patient purchase programs as well. And there are various clinical trials to support the data for Risdiplam. So Firefish was a trial for type 1 SMA, Sunfish for type 2 and type 3, Jewelfish, the trial from 6 months to 60 months treated with SMN targeting therapies other than Risdiplam. There is a combination therapy is what is being studied in Jewelfish, and Rainbow Fish is for the pre-symptomatic babies with SMA. The only DCGI approved drug for SMA in India is Risdiplam. So there are no specific laboratory investigations for Risdiplam. However, blood investigations as a routine, as a part of multidisciplinary management, every 6 monthly we do their routine bloods like complete hemoglobin, vitamin D levels, calcium. We do look at the renal functions and liver functions once in a year. So that is what has been used for Risdiplam monitoring as such. Ophthalmologic assessment has been done 6 monthly because there were some preclinical retinal macular degeneration which was observed in animal studies. But when the studies were conducted later on in patients with SMA who are receiving Risdiplam by Robert C.S. et al., he did not observe any retinal macular degeneration. So one good effect, at the same time, the bad effect with Risdiplam is gaining a lot of weight. So we have seen children gaining a really good amount of weight with Risdiplam. And one of the reasons was regarding the leptin and ghrelin metabolisms, the changes in the leptin and the ghrelin level that takes place with Risdiplam. And less muscle wasting is also happening after giving Risdiplam. The challenge is, again, it's a lifelong drug. So the cost is a major effect because they have per year, they need to take about 60 to 70 lakhs would be the cost of this medication. There are no drug related direct side effects with Risdiplam. Next came the gene therapy. So we all know about the gene therapy. It is the good part of gene therapy is it is a single time infusion. You just have to give a single IV dose over a period of 1 hour. That's all is needed. But the cost is a major factor over here, the hindering factor. So far in India, around 105 children have received gene therapy, and they have received gene therapy through managed access program, which has been provided free of cost, and early access request program, that is after the crowdfunding, they get the gene therapy, which has been provided by the company. And tax exemption has been done by our government, and there have been various studies again to support the use of Zolgensma, but the studies have all been limited to type 1 children, that is a START and the STRIVE study. The SPRINT is a study for SMA of all types, which is still ongoing, a pre-symptomatic less than 6 weeks of age as well. STRONG is a study on intrathecal gene therapy. Then there is a STEER study on intrathecal gene therapy as well. So we have seen really good results with gene therapy also, like a child who was barely able to hold his head in the prone position was started holding well above the surface at 3 months. After 3 months of receiving gene therapy, he started to get down from the cot by himself. This is an SMA type 2 child with a 3 SMN2 copy numbers, and he's doing pretty well with after 8 months into gene therapy. And after 1 year into gene therapy, he is able to stand against the wall with support. And now it is like 3 years post gene therapy, he can even walk with support. So type 2 child is doing so many, able to achieve so many milestones with the help of gene therapy is really a good positive nature aptitude for us. And we all know about the monitoring part of gene therapy, where we need to monitor the platelet count, the troponin I, and the liver functions. Of all the things, we all know the liver function is something which is very notorious, and it has given us a lot of challenges in the management. And Anne ma'am would be the best person to describe on that. Because ma'am had 2 patients who had a fulminant liver failure, and they were managed with high-dose corticosteroids. The studies have reported about thrombotic microangiopathy, but none has been seen throughout India. And death has been seen as a natural course of SMA and not because of the therapy as such. And transaminitis has been seen in majority of the patients. Many of them have remained asymptomatic, but as I already mentioned, some 2 patients have had fulminant liver failure. And thrombocytopenia have been seen in many patients recovered spontaneously. So in the real world literature, this is a European data. They have also mentioned about the transaminitis and pyrexia and vomiting as a serious adverse events. The RESTORE data also has mentioned about hepatotoxicity in 49 out of 167 children, transient thrombocytopenia in 23. Now, RESTORE is a very interesting study on a prospective, multicentric, multinational observational registry, where they have had 167 patients who have infused with gene therapy, and they have followed it up for the 4-year period. So the challenges faced, we all know that the cost is a major challenge, and long-term efficacy and safety profile is still in underway, because we all have a data of like 15, 16 years. We do not know whether the effect is going to wean off after some time, whether the repeat dosing is required, and what about combinations? All these are a question mark in front of us. So next came the very interesting part, which has been going on for the past couple of years, is the combination therapies. So the combination therapies, the therapies have been proposed by Proud and Mercury et al. And the therapies have been divided into monotherapy. We all know monotherapy is a single drug. Whenever we are giving, it's a monotherapy. Add-on therapy is somebody who has already taken onasemnogene, and nusinersen or risdiplam is ongoing. Transient add-on is we have taken gene therapy, and nusinersen or risdiplam is transiently added. Combination is initially was treated with nusinersen and risdiplam, and also given gene therapy, and these medications are ongoing. Then there is bridge to onasemnogene and switch to onasemnogene, where usually we all follow this bridge and the switch therapies, where till they get the gene therapy, we bridge them with one of these agents, either mostly it is a risdiplam, and then we give the gene therapy for these children. So from the RESTORE data also, we have seen that majority in the RESTORE data were also bridge and the switch therapy, where they have transiently used risdiplam, and then they have given gene therapy after that. So then came the most interesting part, which I already mentioned before, was the anti-myostatin. So we all know that myostatin is a negative regulator of muscle mass. So imagine all of us are working out and building our muscles, and if we don't have myostatin, we'll end up all look like Hulk. So it is a myostatin in our body which help us to cut down the muscle bulk. And for children with SMA, especially by preventing this cut down of the muscles, they can regain whatever amount of muscles that is there in their body. That is the idea which was taught, and because of that, the anti-myostatin came into effect. So the 2 anti-pro-myostatin drugs in the clinical trials are in combination with nusinersen or risdiplam. So the idea that was believed is, we already given SMN gene dependent therapy. Along with that, if we give an anti-myostatin, probably the benefit would be better, which has been proven in a number of studies, of which one of the drug is apitegromab, which is also called SRK-015. It is an anti-pro-myostatin monoclonal antibodies. They bind to pro-forms of myostatin, inhibiting myostatin activation. So phase 1 was a placebo-controlled study for safety, pharmacokinetic, pharmacodynamic profile. The active phase 2 was efficacy and safety in the later onset SMA, like type 2 and type 3 SMAs, which is a TOPAZ study. And the TOPAZ study results after 12 months and 24 months have shown a significant gain in the motor functions. Phase 3 is a later onset SMA, received risdiplam or nusinersen in the background and now taking the apitegromab. So this is the chart which tells us that the apitegromab either binds to the pro-myostatin and also it also binds to latent myostatin. It prevents a further process of the myostatin acting on the muscles and thereby increases the potential for the greater muscle mass and strength. So the other drug is RO7204239. I don't know why they keep the complicated names. Maybe I should ask Anne ma'am after that. There is recycling and antigen sweeping monoclonal antibody. It is subcutaneous and it binds to human latent myostatin and blocks its conversion to mature myostatin. So previously mentioned apitegromab is an intravenous medication which was given like every 4 weekly, whereas this RO drug is something which is subcutaneous, and recent studies on combination with risdiplam in ambulant patients with SMA has been going on. So these are the current available. We know the currently available therapies are nusinersen, onasemnogene, and risdiplam. The newer modalities which are ongoing are Ascend is a trial where they are trying an increased dose of nusinersen. So the commonest dose that we give is 12 milligram per 5 ml. So they are increasing this dose and giving it, that is the Ascend trial. Switch therapies, that is the Devote, where the high dose nusinersen in patients previously treated on risdiplam. So they are trying a combination of 2 SMN dependent therapies. Then the combination with SMN independent therapies, that is apitegromab, is Topaz or the Sapphire study. And SMART and the STRONG are the studies that have been ongoing, and the STEER trial is one which is ongoing with onasemnogene, abiparvovec. Risdiplam, that is a jewelfish, which is risdiplam in patients previously treated with gene therapy, nusinersen. Manate and Sapphire are the ones that are going on with the myostatin inhibitors. So for the pre-symptomatic patients as well. So the pre-symptomatics is where the treatment has been initiated before 6 weeks of age, before the symptom starts, and they are the ones which can be identified by newborn screening. So for which the nurture, the nusinersen has been tried, and 23 out of 25 patients achieved walking with assistance. That was type 1 SMAs, and 22 out of 25 achieved walking independently. Those were type 1 SMAs as well. The SPRINT, that is the onasemnogene, abiparvovec, 2 and 3 copies of SMN2 gene treated before 6 weeks of age all survived and none required nutritional or respiratory support. And rainbow fish risdiplam has also been showing convincing results in treating the pre-symptomatic patients. So the way forward for us is again the newborn screening. I know all of us, they are thinking that when many of our patients are not even getting a single drug, the newborn screening is a dream for majority of us. It is, but if we actually try, and if our government also gives a lot of support, we can do newborn screening, provided when we identify these patients at birth, we should be able to provide at least one medication to them. And we also need Indian specific standard of guidelines for the treated group, because more and more the children are getting treated. We are facing new challenges, like the type 1 are behaving like type 2. They are sitting. So once they are sitting, naturally the scoliosis angles are increasing. Again, it comes to a question as to when to operate, how to operate, and how many times they would need a revision surgeries. Next comes a question, the type 2 behaving like type 3, but they have hip dysplasias. So whether to operate, whether not to operate, what kind of orthosis to use. So all this becomes a question mark, and we do need an Indian specific standard of guidelines for this treated group. Thank you. Thank you.
Sir, you're on
Madam.
mute. HVS, sir, you're on mute. Sir, you're on mute, sir. Dr. HVS, you're on mute.
Dr. Smilu, thank you very much for the exhaustive coverage of the currently available therapies for SMA. Do I understand that gene therapy has the maximum benefit as of now?
No, sir. Whatever we have seen is all the three has
All of
got its own type of benefit. We
Okay.
cannot actually compare one with the other. It is difficult. And one thing that we can say is earlier the treatment we provide, the better the children are, no matter whatever therapy we are providing.
But there may be some criteria to select which one to give to which type of patient.
Yes, sir. But that a particular criteria for us, it is like in Indian scenario, whatever is available, we are giving. That is the fact that we are doing. Because earlier, like in Kerala, as such, one good thing that we have is we have risdiplam that is being provided, so free of cost. So the earlier we diagnose, we refer to the center of excellence, we get risdiplam immediately. So the child is getting at least one drug, so we are also referring at the earliest possible.
Because most of them are research molecules, so there will be exorbitant cost. Particularly in Indian rupees, it will be unthinkable cost it is. Anyway, so can we move on to the next speaker, Anne, or you want to continue the discussion here only?
No, sir, please move on, sir. Thank you.
We'll go to the next speaker, Dr. Ramesh Konanke. Am I
No,
right?
sir, Dr. Radhika. Dr. Radhika.
So next speaker is Dr. Radhika Manohar. So I invite Dr. Radhika Manohar for the next speaker. And Radhika Manohar is an adult neurologist and a pediatric neurophysiologist at NHCT Bangalore. She has been doing complex work with both children and adults, mainly for neurophysiological perspective, including performing time-consuming and difficult studies such as single fiber EMG to look at neuromuscular junction defects and motor unit number estimation to look at healthy and viability of the motor unit, and thus helping evaluate who could potentially benefit from newer therapy in SMA and when temporarily. I must confess that very few people take up the ENMG. Now conduction is done by the technician. So like EEG is done by somebody and I go through the EEG and then report at my leisure. Similarly, nerve conductions are done by the technician. But EMG requires a lot of patience and time. First is time, then patience to do it is very, very important. And it is so much operator dependent. We depend on the report of the electrophysiologist. There is no way we can see for ourselves completely, if I understand Dr. Radhika correctly. So in that way, I think we must compliment people who are passionate of doing EMG because it is very helpful in certain types of neuromuscular disorders. Now I ask Radhika to start her talk, please.
Thank you very much, sir. I hope I'm audible to everyone.
Yep. Yes.
I share my screen. And I think my screen's visible as well, isn't it? Yes. Yeah. So my talk's actually really brief and not as exhaustive as Dr. Smilu's talk. So because I'm just focusing on the electrophysiology behind SMA. Since most of the diagnosis of SMA is made from a clinical and genetic point of view, the role of an EMGer has come down to a great extent, but only in very specific, sort of clinical scenarios are we actually of any use anymore. This is just to remind everybody what an electrodiagnostic picture looks like in a child with SMA. Those are the sensory responses at the top and then the motor nerve conduction study at the bottom. What I would like you to look at is the amplitudes. You can see that the amplitudes of the median, ulnar, the sural, and the plantar sensory responses. These are the easiest responses to test in a little child, in a little baby. You can see the amplitudes are beautifully preserved and they're very normal, and the velocities are obviously normal. But what you'd expect to look for any kind of axonal loss is the amplitudes. But the sensory amplitudes are normal. But here you can see that the motor amplitudes are severely reduced. In a little baby child, it should be about 4 millivolts, 5 millivolts. You can say it's 1.3 millivolts. It's microvolts in the ulna, and it's quite tiny below as well. And the conduction velocities are not significantly reduced. It matches the loss of fast conducting fibers that you can see in the amplitudes here. So normal sensory responses are reduced motor response amplitude. And again, the EMG findings. So as Sir said, we need to do the EMG ourselves. We don't have a technician who can do that, unfortunately. And the EMG has to be put in context with the child that we are seeing or with the patient that we are seeing. So in this particular case, you can see that there is active denervation mainly in the thoracic paraspinal muscles, but more distally in the limbs. The denervation is more chronic with reduced interference patterns, sometimes single units in the biceps. For example, this is an EMG of the biceps here. These are different children. Just want to show you what it looks like. So that's a deltoid, and that's thoracic paraspinal muscles as well. So it's important to do the thoracic paraspinal muscles and the genioglossus, which is the tongue, because that's how you are able to demonstrate loss of motor axons or motor neurons all the way from the bulbar segments down to the lumbosacral segments like the tibialis arteria. So normal sensory responses, reduced amplitude of motor responses, and as you noted here, widespread acting on chronic denervation, but depending on the stage of the illness and on the type of the SMA 1, 2, or 3, you'll find that there's more active or there may be more chronic denervation. I'll explain that to you in a minute. And all this would then fit with electrophysiological localization to the anterior horn cell, resulting in what we call a diffuse anterior horn cell disorder. Not specific to SMA, I need to say that, not specific to SMA, but any anterior horn cell disorder, including progressive muscular atrophies in adults or amyotrophic lateral sclerosis. What are the nerve conduction study stages in SMA? So as I explained before, normal sensory responses, reduced motor responses, and this is just your old peripheral nervous system schematic diagram where you can see that our localization is to the preganglionic level. That means the anterior horn cell level there, where the sensory responses are normal and the motor responses are reduced. So what more information can we get with these motor amplitudes? So you have CMAP amplitudes, and we call them what's known as maximum CMAP or a maximal CMAP amplitude. You can use the median nerve recording from the abductor pollicis brevis, or you can use the ulnar nerve recording from the abductor digitoid minimi. And as you can see, the couple of studies that I've shown here, you can use CMAP amplitude reduction or improvement in patients with therapies. For example, patients who are undergoing nusinersen, for example, you can use your maximum CMAP amplitude to try and monitor the therapy. So they tend to be reduced, the CMAP amplitude. And there are studies like the ones here where you use the maximal CMAP to look at the sort of the improvement or chart the recovery as the patient improves. Now, the problem here is that a lot of reinnervation may take place, and the reinnervation may be part of the disease itself, if it's SMA type 3, for example, or the reinnervation may be part of the or part of the medication, due to the therapy, and this is where we cannot make a clear distinction here. So then that's the drawback of using CMAP amplitudes or motor response amplitudes to try and monitor your therapy. Again, as you can see, there's another study here that I've highlighted, looking at, again, nusinersen in type 2 and type 3. And again, there is evidence that there's an improved motor amplitude responses in younger age groups and those with shorter disease duration. So you can use your maximal CMAP responses to try and monitor these patients on Spinraza like this. Now, coming to the EMG, so those are the nerve conduction studies. So like I mentioned before, the sensory nerve conduction studies are of no use. They're usually normal in the vast majority of SMA cases, just case reports with some DRG involvement. That's dorsal root ganglion involvement, but sensories are normal and motors show these reduced amplitudes. But in EMG, you tend to see fibrillations and positive sharp waves. As you can see here in this picture here, these are positive sharp waves. And this indicates a membrane instability. When you activate, so this is the muscle at rest, and when you activate the muscle, you can see that the motor units are recruited like this, and these motor units that are recruited are firing at a very high rate because of significant motor unit loss as part of the disease, as well as the motor units themselves show sort of long duration. You can see the prolonged duration, a little bit of polyphasia or polyturns indicating reinnervation. And in very end-stage disease, the motor units can look very short duration, small amplitude, almost like a myopathic muscle. So these are the EMG changes. They don't really particularly help us in monitoring the disease course or in monitoring therapy. So it's not like the motor amplitudes, which could be helpful. And just to sort of a little table to just help you put these things together. So you've got SMA type 1, 2, and 3 here. You can see in the most severe ones, you can see the motor amplitude reductions and the motor unit number estimation reductions, which we'll explain a little bit later, is much more severe with a lot of active denervation. The recruitment is severely reduced and the motor units are quite large. But as the sort of disease moves from type 1 all the way up to type 3, you can see that the motor amplitude reductions are not that severe. And sometimes in some cases, in adult onset, they can be quite normal. Motor unit number estimation, the MUNI tests that you do as well, doesn't show that degree of reduction. And the active denervation changes such as fibrillations or positive sharp waves may not be present all the time. And the recruitment is also not as bad as SMA type 1, for example, while the motor units themselves have renovated largely and become very large motor units. So that's the sort of difference that you'll see depending on the severity of the SMA. Just a quick word on what happens in neuromuscular junction SMA, especially since therapies are being tried there. So there was some evidence of involvement of the NMJ in the form of repetitive nerve stimulation studies at low frequency stimulation, 3 Hertz or 4 Hertz, showing a decrement of the responses. But overall, it's not very clear what this represents, this decrement, particularly since the decrement was mainly in the limb muscles, because we do know that sometimes you can have decrement, what we call a false positive RNS, most likely secondary to reinnervation that takes place in the muscles. And we see this very often in ALS cases. We also see them very often in muscular dystrophies, for example. So they have been reported in SMA, and the significance is not very clear. It could still be part of the reinnervation. Personally, I haven't seen, to be honest, I haven't done that many SMA children in the last few years, particularly because of genetics being so freely available, and rightly so, the first point of call. But there was one case, I think it was 1 or 2 cases where I did do RNS just to see, and it looked like an ALS RNS where there was a decrement in the spinal axis nerve. But again, it doesn't really mean anything to us now. We can't really use it for therapy or for monitoring the disease. So then come to motor unit number estimation, which is what it's mostly within research realms. Sorry, the MUNI or motor unit number estimation is still very much within sort of research range, but it's something that is quite easily accessible. Most of your machines may have this option, which you can learn to do really. It's not that difficult. So it's a sort of method, it's a motor conduction method, sorry, to estimate the number of motor units in a muscle. So you try to estimate the number of motor units, because motor CMAP responses, the motor responses don't give you the number of motor units. So it can be used in diagnosing diseases, in monitoring progression of diseases such as ALS, for example, or SMA, as in our case. So the technique that I tend to use, I'm literally learning it, to be honest. So I'm not an expert by any means, but I tend to use the incremental multi-point method. So first, what you need to do is, for example, this is a motor study from the median nerve, recording from the abductor pollicis brevis and stimulating the median nerve here. You first obtain a CMAP from the APB, or abductor pollicis brevis, using supramaxillary stimulation, like so. And then you have to capture these single motor unit potentials by incremental stimulation, looking for an all or none response. And that the machine then has an algorithm already built in, and they will actually give you your MUNI number based on this calculation, your maximal CMAP or your supramaximal CMAP divided by your mean single motor unit potential here. So supramaximal CMAP divided by your mean single motor unit potential here. So it's not perfect, but it's one of the methods that can be used. Other methods are what's known as Munix and M-scan, CMAP, M-scan. These are much easier to use, to be honest. The one that I described here, 20 minutes, and we need a child who's cooperative. Unfortunately, quite a few of the children are quite floppy and quite weak, so they tend to be pretty cooperative, and we are able to do this method, but it is time consuming. While the Munich and the M-scans are they're all validated and they're very quick to do. Maybe just one motor response is enough. That's all you need. So these are just other examples of other methods. Sorry. So what happens to the MUNI, the motor unit number estimation? So this is a study that gives you a nice little picture. So you see, this study looked at changes in motor unit numbers or motor unit number estimation, as well as maximal CMAP. And it found that there were changes in MUNI in all three types of SMA. And the reduction in the maximum CMAP value was most severe in SMA2, interestingly, not in SMA1, as the children were sort of longitudinally tested. And age-dependent decline in MUNI and maximal CMAP value was the same. So with age, the decrease in MUNI and maximal CMAP amplitude value was the same in both SMA1 and 2. And if the copy number is less than 3, obviously it correlates with a lower MUNI and lower maximum CMAP values. But rather than MUNI in this study, they found that the maximum CMAP values correlated best with functional outcomes. Maximum CMAP is just a supramaximal median. They use a supramaximal median study, but you can use a supramaximal median or ulna. Whatever you use, what you need to do is to make sure that you keep testing the same child with the same parameters so that you can look for a trend. So as far as MUNI is concerned, with regards to therapy, they have found that there is definitely an increase in CMAP amplitude as well as MUNIs in patients with nusinersen, as you can see here. So overall, what is the role of EDX electrophysiology in SMA? Like I said before, we are not really needed for diagnosis anymore, not very often, apart from these kind of rare situations where there's a clinical presentation, particularly in adults, where it's a symmetrical proximal limb presentation, which could easily be a muscular dystrophy or some sort of myopathy as well, or the non-5q related SMAs as well. So this is the only time we are called in to help make a diagnosis. But otherwise, there is a new role now for us if we can try and take the time to do the MUNI studies to look at response to therapy. So you can use these electrophysiologic markers as baseline, and then following the therapy, different types of therapy, to see if there's actually genuine response to therapy. We can, of course, chart the disease course. You can just do serial studies, MUNI studies, to see how the disease goes, but I'm not sure how much that will add to our existing knowledge, because we know that MUNI reduces as the disease progresses. But as far as I'm concerned, I think the response to therapy and what MUNI can add to that, along with your CMAP amplitudes, I think that's where we probably have a better role to play as an electrophysiologist. Thank you very much.
Sir, can't hear you. You're on mute. Sir, HVS sir, can't hear you.
Automatically it becomes mute, I think. Okay. Thank you, Dr. Radhika. As I said earlier, there are very, very, very few neurologists who have the time and passion to do exhaustive electro. Again, what is happening? Am I audible now?
You're audible, sir.
Okay.
Automatically, some people put their thing unmuted, but the ORDI people are watching and they're unmuting them. They're continuously muting them. So which is why you're not getting as much disturbances as a normal meeting.
Okay, okay. So I must compliment you for the intensive and exhaustive electrophysiological study. And we have to really search for somebody who is ready to do this sort of a EMG especially. We have occasions where patients come with wasting of the distal muscles of the hand. And there is one very eminently treatable condition, multifocal motor neuropathy, for which we depend very much on the electrophysiologists to tell us about the add-on to the diagnosis of multifocal motor neuropathy. And very interestingly, steroids are not only not effective, it may even worsen. So IgG is the one which is to be immunoglobulin. And second one is about our juvenile spinal muscular atrophy or monomelic atrophy, as Dr. Gauri Devi had described from Niemann, or Hirayama disease, which is a self-limiting disease occurring in the juvenile patients as they are growing up, the neck extends and the spinal cord gets compressed by the displacement and all. So here again, we require the help of an electrophysiologist who can be definitely helpful for this. Occasionally, in adult type of SMA, as you people have described, proximal muscle weakness, CIDP is another eminently treatable condition, which may be mistaken for adult type of SMA. So here again, we require an electrophysiologist to help us. So I think These are all very important specific disorders where we depend heavily on electrophysiologists. So now I have got Radhika to refer to whenever I have got a problem. Thank you.
Thank you, sir.
Now we move on to the last speaker, Dr. Ramesh Konanki, one of the key specialists leading the treatment for SMA in the country and is based in Rainbow Hospital, Hyderabad, which is a very famous hospital for pediatrics. He has vast experience dealing with children affected with SMA and has been administering and managing these individuals. Their center has administered all the available disease-modifying treatment in SMA, nusinersen, resdiplam, and gene therapy, and have had to deal with these children who go on to have other issues after their natural history has been modified. Maybe we would like to look into what are those other issues once it has been modified. On to you, Dr. Ramesh Konanki.
Thank you very much, sir. My talk will be very brief. So I'll be mainly covering the non-medicinal part of care of spinal muscular atrophy. Although till 2018-19, this was the only thing that was available to children with SMA and most of the other neuromuscular disorders, because there was no definite treatment available, it was neglected. So in fact, most of the multidisciplinary centers that have come up, including our own center, were non-functional prior to availability of the disease-modifying therapies. So after that, I think to get the optimum outcomes with whatever medications are available, so this has become a cornerstone of SMA care now over lifespan. So definitely this is the SMA care cannot be done by one person or two people. So it is a multidisciplinary in a truest of the sense. So where the neurologist role is actually more like a coordinating person with most of the other care components provided by other specialists. So especially the physical therapists, orthotists, the pulmonologist and intensive care team, the orthopedician, spine specialist, including neurosurgeons who take care of spinal deformities, the nutritionist. So they are the main pillars of the multidisciplinary team. And Anne has been doing wonderful job. In fact, we started our MDT clinic after looking at their model, and hopefully we are trying to do the best possible. So as I said, before the disease modifying therapy is available, this was the only treatment available. And because there was no hope for most of these children, especially type 1 and type 2, most families were not convinced about why this has to be done. But 2018 onwards, once the drugs were marketed, these have become very important now. So this is very critical to get best outcomes in those children who are receiving these therapies. So of which the most important part of this non-medical management is the physical therapy. And this is the cornerstone of multidisciplinary treatment. So this has a both preventive aspect as well as treatment approach. Treatment, obviously, wherever there are weak muscles, to strengthen the muscles or maintain the mobility of the joints and muscles. So that becomes the key component. Whereas preventive is the prevention of contractures and prevention of certain deformities, especially type 1 and type 2. A lot of them are non-ambulant patients, so they tend to develop contractures over time. One, because of the disease progression itself, due to progressive muscle weakness. Second, because of non-mobility or not using those muscle groups. Then deformities, including the spinal deformities, hip dislocations, chest deformities. These are the other things which have to be dealt by a physiotherapist. So in fact, this is one of the toughest and most tiring job, I must say, out of all the multiple disciplines that are involved in the care. So this is very, very key to the whole teamwork. And obviously, this has to be tailored to the functional status of the child. So the physical therapy for a non-sitter or type 1 may be different, and it's quite different from the sitters and walkers. So depending on what is the functional stage of the child, either treated or untreated, the therapist has to constantly tailor the different aspects of physiotherapy. So these are some of the components, but not all, because I'm not an expert in physiotherapy. So daily use of seating systems to see that the seating or positioning itself is proper, so that they don't develop into go into spinal deformities or chest deformities. So maintaining a proper correct posture itself is very, very important, which is often neglected because most of these non-ambulant children either carried or just left on the bed. So their positioning is a key area. Then wherever there is a potential for deformities, especially the spinal deformities, so they need to have a bracing, the spinal brace or the cervical brace as needed. Then some customizations for allowing the abdominal breathing, which most of these children are abdominal breathers. Then orthotic support for upper and lower limbs, one as part of preventive care to prevent contractures and also to maintain the range of motion, especially the ankle foot orthosis or the knee ankle foot orthosis, or knee stabilizers and immobilizers, hand splints in some children with more advanced disease. So these are some of the components of physiotherapy and orthotic support. Then in those children who are non-ambulant, the mobility systems, including manual wheelchairs or the motorized wheelchair, that becomes another component of their mobility. Then other next very important aspect is the pulmonary care. And this is unfortunately one of the commonest cause of mortality in children with SMA and most of other early onset neuromuscular diseases. So because of the weak intercostals, so early and preferentially intercostals become weak in children with SMA, and relatively the diaphragm is a bit stronger, especially in the earlier stages. So because of intercostal and paraspinal muscle weakness, these children are prone to develop certain deformities. One is this chest deformity called as parasol rib deformity, as we can see on the right side of the screen. So this is almost like an umbrella which is half closed. So this specific deformity is given the name of parasol rib deformity, where the diaphragm is relatively stronger. It tend to maintain the position of the lower part of the chest, whereas intercostals being very weak, so they tend to give way. So there's a kind of collapse of the upper and mid thorax with relatively preserved lower thoracic contour. Then kyphoscoliosis is other deformity, which is not only because of paraspinal muscle weakness, but also because of the respiratory muscle weakness, it tend to worsen. So the result of these deformities, both rib deformity and the spinal deformity, is the reduction in the lung volumes and capacities over time. And also they increase the risk of pneumonias and respiratory failure later. So as I mentioned in the beginning, the initial approach for pulmonary care and in fact other disciplinary treatment, including orthopedic care, was more reactive in earlier years, where only when there is a problem, then the solution was looked at. Like if there is a pneumonia, then you treat pneumonia, or if you have a scoliosis, you treat scoliosis. That was the reactive approach. Whereas with the availability of disease-modifying therapies, the approach is more proactive now, and rightly so, because this is something which will definitely improve the quality of life and also reduce the mortality. So the cornerstone of pulmonary care is the airway clearance. Because of the poor cough, a lot of these children develop repeated pneumonias, in turn giving rise to other systemic complications like poor weight gain or weight loss. So the chest physiotherapy or using devices like cough assist to improve the airway clearance is a cornerstone of lung care. Then nebulizations to better clearance of the secretions. Positioning is also very important, and oral suctioning to keep the upper airway clear. And in older children who are cooperative, they can be offered spirometry. So this is one part of airway clearance and improving the lung volumes. Then other important thing is actively looking for sleep disordered breathing. So this is another common thing which was ignored earlier. But now most of us are trying to look at more actively. So early identification of sleep disordered breathing through overnight sleep studies, and then early initiation of home non-invasive ventilation like CPAP or BiPAP mode. So which are fortunately now becoming more affordable now at lower cost. And then other, even the spine support and spine care is also important to prevent lung morbidity. So these are the individual components of pulmonary surveillance and the intervention. I'll not go into details. The other important component of MDT care is the spine care. So as we said earlier, the risk of kyphoscoliosis is highest in type 1 and type 2. But because most type 1 children did not make it even second or third birthday earlier before MDTs were available, a lot of spinal care earlier, say about 7-8 years back, was in type 2 and type 3 children, because they are the ones who were living longer and used to develop kyphoscoliosis. Now, as the natural course is definitely modified, type 1s are becoming type 2. So more and more type 2 children, we are seeing kyphoscoliosis now. So we need to have some periodic monitoring for looking at the degree of scoliosis, and to have both preventive as well as the treatment protocols in place. So prevention, definitely there's a limited chances for prevention, like with appropriate positioning of the child in supine position, both when he's awake as well as sleeping is very important. Then in an upright child, either at home in a say in a home environment or in an ambulance setting where they're mobilized in a wheelchair, the positioning becomes very, very important. And the spinal bracing is one component to prevent or delay the kyphoscoliosis. It can't completely prevent because the disease itself is progressive. But in those treated children where the disease is going to be stabilized in most of them, the bracing plays an important role. So depending on the degree of scoliosis, there are standard approaches to how to deal with them. So once in 6 months or once in a year, depending on the risk group, children should undergo spinal X-ray. It depends on the co-ops angle. If it's less than 15 to 20 degrees, just monitor. If it's going beyond 20 degrees, they definitely need a thoracic bracing and more frequent monitoring to look at the progression. And if it's more than 50 degrees, depending on what is the age of the child, if it's already attained skeletal maturity, is typically about 10, 11 years of age, they can undergo posterior spinal fusion. Or if it's a younger child, 4 years, 5 years old, they may have to undergo other temporizing measures like growing rods or VEPTR. This one of the a child with a type 3 SMA who had quite severe kyphoscoliosis with COPS angle of nearly 55 degrees to 60 degrees, underwent posterior spinal fusion. Now her walking has definitely stabilized. Unfortunately, around the same time, they were also able to procure risdiplam. So that has definitely helped her in ambulation in a better way. Earlier, she was most of the times confined to wheelchair. Now, for a few minutes, she is able to take few steps without support and still continues to use wheelchair other times. Then other orthopedic problem that is commonly seen is the hip dysplasia or hip subluxation. So it can be seen as many as half of the cases, more common in type 2 than type 3. Type 1, again, because of the severe general disease itself, we don't see it often because they don't survive long enough. But in practice, type 2 are the ones where we see more hip dysplasias, and then type 3 also, those who are progressive type 3s. So again, preventive care is very, very important to minimize the morbidity. And the disease modifying therapies have only made it more difficult and challenging for us to look for best possible therapies. Again, positioning in all both awake state and sleep becomes very important. This is often ignored or neglected part, the positioning, because the stress is so much on physiotherapy, chest care. Sometimes we forget the very basic part of advising the parents about what is the best position to keep the child in different times of the day, and appropriate seating systems. And is that you?
No, it's not. It
Okay.
just got silenced.
Okay, I thought it's a time reminder. Okay. So then
No
seating
reminders.
in those non-ambulant children, and obviously surveillance for those children who are at higher risk for hip dysplasias, especially the type 2s, and the severe type 3s are the ones who are going into this particular problem. So I'll not go into this. Is the growth modulation treatment that some children undergo to stabilize and minimize the progression of the hip deformities. Then other important component is the nutritional management. So depending on the type of SMA, there is both the problem of underweight as well as overweight. The type 1 children and most of type 2 children are mostly underweight because they have a lot of issues with the nutrition. One, they may be nutritionally deficient as such, And many of them, especially type 1s, have swallowing difficulties due to which their intake itself is low. And recurrent pneumonias can add to the caloric expenditure and result in poor weight gain. And sometimes they have gastroesophageal reflux. So there are multiple components which contribute to poor weight gain or failure to thrive in these children. So the nutritional management becomes quite important. So sometimes we see the child is getting some medication, disease modifying treatment, but nutritionally is so severely affected that even the medication may not show much effect. So whereas in type 2, little milder type 2s and type 3 children tend to be more overweight because their ambulation is very limited, but they're able to sit in upright position. They have no swallowing difficulties, so they tend to put on weight. So that is another challenge in this group of children. So as part of surveillance, we should always look for any symptoms of reflux and treat them appropriately. Nutritional supplementation, all the possible supplementation, including multivitamins, vitamin D, calcium, this becomes very important. And those children who are failing to thrive despite taking all these measures, they may require gastrostomy feeding like in one of our children. Then bone health is the other thing which has effects from multiple factors. The two commonest things are, one is the primary effect of disease itself, where SMN is known to interact with osteoclast stimulatory factor and result in osteopenia. Then secondary, because of other systemic problems like immobility, nutritional deficiencies of various things that can result in poor bone health. So again, periodic monitoring of calcium levels, vitamin D levels is very important, at least once in 6 months or once in 1 year in ambulatory children. And type 1 on treatment and type 2 children may require DEXA scan. And depending on the results, we may have to either supplement it. And in more severe symptomatic cases where they're developing fractures or the bone mineral density is very, very low, some of them may benefit with periodic bisphosphonate infusions. Then last but not least important one is the immunization. So other than the routine immunization as per the national schedule, they should specifically look for these immunizations, because these children are at risk for pneumonias, especially pneumococcal Hib. These should have been vaccinated in all children with SMA, and annual influenza vaccines, at least to reduce the risk of seasonal infections. So, immunization should be looked at in all younger children, especially below 3-4 years. I think I'll stop it there. Thank you very much.
Okay. Thank you, Dr. Ramesh, for the paramedical or disease modifying therapy is one aspect of it. The maintenance of various other parameters in the same given patient is another aspect, which is very, very important, because just addressing one particular core doesn't make the whole thing treatable. So I think you have taken an exhaustive interest and also the literature and your own interest. So I think that's a very important aspect of it. I have a question. So when an adult comes with wasting of the upper limbs, the question is it a motor neuron disease or is it an adult type of SMA? Of course, you will say that look for a SMN gene. But if the SMN gene is absent, how do you still make a diagnosis of adult SMA? Clinically, we look for upper motor neuron signs in the lower limbs, but it may come much later. At a given time, is there any other method where the gene is not giving you the information for adult SMN, but still you can make a diagnosis of adult SMA?
Sir, I think in type 3 and type 4, as far as I'm aware, although we don't see so many adult cases being pediatric neurologists, but I think their predominant muscle weakness when they start having symptoms is the lower limb proximal muscles. So more than upper limbs, they would have most of them, whatever I have seen, adolescents or young adults. Anne can correct me, or Dr. Radhika, they can correct me. So they come with the hip girdle weakness most of the times. So LGMD is the one which is often we confuse with. So, yeah.
But sir, if I may. Sir,
Yes,
this is
please.
a question we have to ask you. You have the most experience with this than either of us. I have, because I predominantly practice neuromuscular medicine. So I end up seeing adults.
Hmm.
So I end up seeing people up to 40 years as well. But I usually see them, assess, analyze. So recently, Dr. Radhika had a patient whom I saw who was asymptomatic. She wanted to plan her pregnancy. Radhika has got the Muni for that patient. So she's 40, no? 40 something, Dr. Radhika?
Yeah, she's in her 40s. Yeah.
So she somehow, a hi-fi couple, postponed pregnancy, then said, okay, we want to fall pregnant. So she went and somehow got genetics done for herself and her husband.
So carrier screening.
No, she did entire genetics.
No,
And she
that's
found
what
out,
carrier screening for SMN. They intended to do carrier screening.
There is no
probably.
family history of SMA. She just
Okay.
did entire genetics and she found out she has homozygous SMN mutation. And she found out she's diagnosed herself with SMA. Then she Googled and said SMA Dr. Bangalore and she came to me. And then I was thinking, okay, what am I doing with this woman? I have no clinical signs. Her upper limbs are fine, her lower limbs are fine, reflexes are preserved. We couldn't even do physio assessment because everything is out of out. So I sent her to Dr. Radhika. So Radhika did Muni. When she did Muni, she got lower limbs abnormal, upper limbs normal.
Normal, yeah. I think upper limbs was 15 and lower limbs was 6 or something.
Four or something.
Yeah, something like that.
It came as a shock to the woman.
She's totally asymptomatic, pre-symptomatic or asymptomatic, whatever.
She's an
yeah.
athlete. She's an athlete. So,
Similarly, in the Hirayama or juvenile SMA, which is a very benign self-limiting disease, at a given time, when you examine the patient as having a wasting of the muscles, how do you go about it? Whether it is a type of SMA or is it a benign spinal muscular atrophy due to Hirayama, because where the prognosis is totally different.
So the thing is, it is blind man and the elephant. Your perspective is different from my perspective. Mine and Dr. Smidhu's and Dr. Ramesh's perspective is different. Dr. Radhika's perspective is different. We will always go with first-time genetics. Because genetics is cheaper today. It's only $4,500. Or if you're in Hyderabad and you want to send it to a government center, it's only 3,000. If you send it to CCMB, if you send it to Medjuram, it's 4,500. As Dr. Radhika knows, exhaustive EMG costs 5,000. So it's a bit more expensive than the genetics. So we usually say, okay, even if we don't think it is, we just do this. But
So
if it is,
all depends on the genetic study.
no, it doesn't depend on that in the sense that it's become cheaper to do. Cheaper, more cost effective to do. And if you have a homozygous mutation, you can't say you don't have SMA. You have SMA.
But my question is, see, we have RA negative rheumatoid arthritis.
Okay.
Aquaporin negative NMO. So similarly, is there a genetically negative? You don't have information, but it still can be a SMA.
Oh yeah. Yeah, that's your 5%.
How do you diagnose that particular part?
Very difficult. That is the one that Dr. Smidhu was talking about. Your 5%, your 5Q non-5Q SMA.
Non-5Q SMA.
Pulling your hair out. And we have, between the two of us, we have many such patients that we literally spend so much more energy doing it.
Yeah, I'll just add. Sir, 95% of them have homozygous deletions, which are picked up on MLPA, but about 5% of actual SMAs, they're truly SMAs, where they may not have deletion, but they may have point mutations. Sometimes you may have to do combination of genetic tests along with MLPA, Sanger sequencing, or exome sequencing to pick up those point mutations.
So, sir, the other thing is, Dr. Radhika knows there are a bunch of patients that we have. There was another question, sir. If you look at the chat box, there was a question here. Something saying, are there other conditions that can cause tongue fasciculation? So, sir, as a clinician, what would your answer be, sir? You want us to answer, or would you like to answer? Tongue fasciculation and anything else other than SMA? You know of Madras motor neuron disease. That's a disease that you know of. That was before riboflavin was detected. So like that, we know of so many mitochondrial disorders which have anterior horn cell affected. Currently, I just saw one in the ICU today who's got frank fasciculations. I saw one which Dr. Smidhu has sent as well. So plenty of them have. They're not SMA. You can technically call them SMA. You can call them They are SMA because they're spinal muscular atrophy. Anterior onset is gone.
Spinal.
Yeah. So these, but what we have to remember is that these are clinical syndromes. So what we think of as SMA is the classical 5Q SMA. So it's better to call it 5Q SMA. The rest of them come with other levels. Either they have a brain problem, they have mitochondrial disease, they have something else. They have so many other things.
What was the question? Fasciculation, is it?
Tongue fasciculation.
Which other
You have
conditions other than SMA you can see tongue fasciculation?
fasciculations. Riboflavin, no?
Fasciculation can be very benign also. So whenever we take a neurology class, next day there will be a couple of students, sir, I've got some fasciculation here. Am I developing motor neuron disease? I said, we don't diagnose only on fasciculation. Fasciculation is a fascicle which is contracting due to innervation of a motor fiber. It can be at the anterior horn cell, anterior root, plexus, or even peripheral nerve also. But what distinguishes the anterior horn cell is it is called as ATM. Anytime you see there will be fasciculation, that is the anterior horn cell. Intermittently you see fasciculation, it can be diabetic motor neuropathy or any other motor neuropathy, even radiculopathy also. So by only fasciculation, we don't make a diagnosis. We always take all the pictures into the consideration to make a final diagnosis. So as I keep teaching my students, a clinician is a master chef who has all the ingredients with him. He has to combine which one he wants to take: electrophysiology, MR scan, genetic study, this and all, plus the patient per se, and then make a combination and give a final clinical diagnosis.
So now you understand why you are the moderator for this, sir. So, but sir, I'm going to throw one more confusion into it. What we have noticed for some of our children with SMA, with active SMA, even type 2s and type 3, not type 1s, there are on and off periods when they do not have tongue fasciculation. So I remember my professor telling me, my neuromuscular professor, Professor Muntoni, telling me that when fasciculation is happening, so this is already SMA diagnosis is made, is when active denervation is happening.
Very important.
Yeah, there may be periods of time in the child's life when that active denervation is not happening, when they don't have fasciculation. We have at least 10% of children whom I've noticed with SMA, proven diagnosis, I know is SMA, who don't have, which makes everything confusing. But you're right in your quote of MasterChef. That analogy is right. There's no complete algorithm. There's no complete answer.
Florid fasciculation is a sign of anterior horn cell disease. I tell the students, when you see the fasciculation, it is the cry of degenerating anterior horn cell disease, not degenerated anterior horn cell disease. Once it is in a quiescent period, you don't see the fasciculation. It doesn't mean that you have not seen, so it is not anterior horn cell. It gives you additional information that it is an actively degenerating disease.
So today I saw a child with florid tongue fasciculation, who's not SMA and whose genetics is negative, who we think has got mitochondrial.
I want to ask you, all these drugs which are there now, they are all in the experimental stage, and of course they are covered by
approved.
the.
They're approved, sir.
Sorry, it is covered by the patent, isn't it? So when is it going out of that so that India can cash in and produce a lot of drugs at a very small amount of cost?
So which is a shame.
When is a patent expiring?
Sir, we're all in the same boat. We're all clinicians. We are just some of us are just, so the three of us are doing research. Dr. Smilu, Dr. Ramesh and me, we're into clinical research now because of this. We were not researchers. We are, just untrained researchers who are just clinicians. But the sheer number of patients and the problems that they have has forced us to do research. And we are learning new things. We're not trained to do this. But the thing is that it is so hard looking at a small bottle of risdiplam, which costs 6 lakhs, which for an adult will only last 15 days. It's such a cheap molecule. It's a simple molecule.
So pharma company is supplying,
Roche is supplying it. Sir, you know what it is.
So when are they going off the patency?
Oh, God alone knows. I don't know.
At
Sir,
least
you have seen. How was IVIG? How were other drugs before, which we thought was so unattainable? Maybe you can give us some guidance on what we should do. We have large numbers. with these who need this.
Indian companies will be waiting once that once they finish that patent product.
But
And
they're also
one last question: what is the longest period of follow-up in these patients, and how they are doing it? They have improved initially and then stabilized, or again deteriorating in spite of treatment, not dropout with patients.
Sir, they have been, so Western data, there's at least 8 years of follow-up. My data, I have 5 years of follow-up. And they're doing well, sir. They get better and they stay the same. The ones who drop out,
What is the longest time follow-up?
5. For me, 5 years.
5 years.
So I think
Four,
we have
four,
the, we
4
have,
years, 4 years.
for them 4, because we started giving it
little
earlier.
early. Yeah.
Yeah.
So they all improve and maintain.
They improve and maintain.
Sir, one important thing I think Anne mentioned earlier in a passing way is, Smilu mentioned, is how early you start the medication. Because if you start them early when most of the anti-Rohan cells are preserved, then they do very well. So first few weeks is the best time to start. So in pre-symptomatic and early symptomatic ones, they develop almost like normal children if they started on one of these disease-modifying treatments.
So, sir, to add to that, Poland boasted that they were the youngest, they gave the youngest child gene therapy, 16 days.
Oh.
Because normally there are many countries which can afford to do newborn screening, pick it up early and give them the gene therapy. But because Netherlands is the only place where that particular gene therapy's antibody can be tested, it takes at least a month to get it, requisition it, and then get the medicine from America to come to them. Even from America to go to Rotterdam, it takes time. So everybody takes minimum 1 month. So Poland had a 16-day-old baby. So that child is doing very well. So many of the newborn screening picked up children, they're doing very well. Now, and most of the Western countries or most of the resource-equipped countries, what they're doing is what Dr. Smilu mentioned. We bridge them, get a diagnosis, bridge them with therapy, stabilizing therapy. So the answer to that is, yeah, we all think gene therapy is the best. Risdiplam, they give Spinraza. So Risdiplam is our poor man's thing, our country's thing. So we give Risdiplam, bridge them, then give gene therapy. And then many of them, there is a wear-off. We sometimes find that giving Risdiplam afterwards is also helpful. Combination therapy. That is what we're doing, but we can't afford to do it. We can only dream of it. But things that we dreamt up in 2019 happened in 2020. We hope what we dream in 2024 will happen in 25 or 26.
Okay.
I have a question to maybe all of you. So recently I came across some papers from North India, PGI Chandigarh, and one more paper on ECG to document fasciculations. You don't do nerve conductions. So some centers don't do NCS now. They just do ECG. In lead 2, they can pick up fasciculations from the intercostal muscles, and that's it. They send genetic testing. Any experience with that? ECG. There are the papers, 2 papers I could see.
That's very clever.
Yeah.
And very indigenous, very Indian.
I'm thinking next clinic I'm going to see, at least in diagnosed cases, if we can pick up.
No, but diagnosed cases we pick up all the time.
No. Diagnosed cases, at least if you know for sure it is there, then suspected cases you can start.
All our patients it is there. So
No. ECG. On ECG fasciculations, I'm saying.
ECG fasciculations there in all our patients.
Yeah. Then
we do ECG regularly for everybody. See, after 5th birthday, so if they're on Spinraza, they get ECG as part of the protocol. Those who are not getting Spinraza, above 5th birthday, everybody gets salbutamol. So if they're on salbutamol, 6 monthly, I do ECG. Every time they come with the ECG, I can see the fasciculation on the ECG.
I saw it, but I thought maybe this is an artifact going on in many channels.
No. Oh. That's not artifact. That's for fasciculation. Okay. I remember my prof teaching me about it, saying that ignore it. This is what ECG in the SMA looks like.
So in
what is Radhika's response? Radhika.
Sorry, sir?
What is your response for that conversation?
I know, I'll be out of a job soon. I have no idea. I've never come across it. It is very clever. It's quite interesting to think that you could do something like that, but no, I'd never really come across that.
I'm not sure it's going to help us with diagnosis because regularly pediatric population, we are not doing ECG. Where are we doing ECG?
No. Like suppose if you have a 4-month-old, 5-month-old coming with suspected SMA, so they say they don't do NCS now. They just do ECG, see fasciculations, then just send MLPA.
Actually, that is a
Of
very
course, mostly it is
very-
clinical diagnosis. I understand. Sometimes for lack of time, we don't even do NCS, just clinically see, send MLPA. That's what we do in some
But
children.
ECG is very useful. That's a very nice thing. That's one
Yeah.
more thing to add to your thing because it's hardly $200.
True.
But invariably, I have seen in almost all children, I've hardly ever seen a normal ECG. Fasciculations are always seen. This was
They
something I
add
was
to it,
taught.
but
during
cannot
training.
replace it.
Add to it, cannot replace it. I agree with you. Yeah.
Okay, are we done or any more discussion? And you are muted.
Sir, I
Are
think
we
that's
done
all.
or any more discussion?
No, that's it. I should thank you, sir, for staying up so late and giving us so many valuable insights, and our excellent speakers. They prepared very well. Thank you so much, Dr. Ramesh, Dr. Radhika, and Dr. Smilu for preparing and giving us all of this. But mostly thank you to Dr. H.V. Srinivas, sir, for
Thank you.
being there and encouraging us. Us pediatricians, so the only person is an adult person, but thank you so much to ORDI as well. And
Actually-
most people who attended are really, really senior people. Dr. Sitaraman is a researcher. Many senior people have attended. Thank you, sir.
Actually, a teacher learns more by teaching the students rather than students learning. So today I have learned a lot more than what you people are learning from each other. Thank you very much.
Thank
Thanks.
you. Thank you, sir. Good night.
Thank you, sir.
Thanks.
Thank you, Anne.
Thank you. Thank you. Thank you.